Hello, everybody. I'm Ira Kirschamo. I am the editor of the Journal for Orthopedic Experience and Innovation. Tonight we have another Zoom open mic session, a very exciting one related to the T-Mini robot, Robotics Reimagined. We have a superb faculty this evening, and we have a full house of people. More will be joining, I could see now. But I'd like to start off with introductions. I'll ask you guys to introduce yourselves, say anything you want about yourselves. Yair, Kissin, why don't you start us off?
Hi, good evening. Yeah, honored again to be here. It's really great. I love this forum that you've created here, Ira. It's really fantastic. So thanks for having me. Yair Kissin from Hackensack, New Jersey. I'm an attending there, orthopedic surgeon specializing in knees. So I'll do scopes, ACLs, and total knees. Been using robotics for a while. A lot of think experience with their original autonomous robot, and then a couple of years ago, been the T-Mini along with Eytan, Debbi, and two other surgeons. So it's been really exciting to see the evolution.
Yeah,
Happy to talk about it.
absolutely. Eitan, Debbie.
Thank you. Good evening, everyone. It's great always to be part of this forum. It's a great community, and I always love the good questions really that come out of the conversation. My name's Eytan Debbi. I'm a surgeon at HSS in Manhattan. I'm a hip and knee replacement surgeon, so my practice is approximately 50% each primary and revision practice. I also have a decent amount of robotics experience. I would say probably kind of grew up in the robotic era. I think we discussed that last time, and kind of I've used pretty much most of the robots on the market, both CT based and non-CT based, and kind of run the gamut of different options. So happy to chat about different things and where we kind of see the industry going.
Right? And Jeff Reeves. Nice to see you.
Hi, yeah, thanks for the invite tonight. Really excited I'm a first timer here at JOEI, so I'm excited to kind of share my experience with T-Mini and one of the true medial pivot knees on the market. So background on me, I'm kind of a longtime drinker of robotic Kool-Aid, and I trained with Martin Roche down in at Holy Cross in South Florida, and so kind of been using robotics a lot since fellowship, and being about 4 years out from fellowship now. I used a few of the different robots on the market, and excited about kind of some of the things that T-Mini brings to the market. I'm
All
at Ohio State, so training residents and fellows up there as well.
right. Is that the Ohio State University?
Yeah, I try not to throw that in people's faces. The more emphasis you put on the more likely you're not actually from there. So
Right. I'm from the Bronx, so it's okay. So I could say that. So I'm going to start this off with this movie and slideshow, and we'll get into that right away. Is that okay? Eitan, we'll start with that.
Yep, that works. Let's just jump right into it. I think a lot of the um, folks here today have seen some robots and have had some experience with some of the technology in robotics. So I think let's just jump right into it. And I think it'll give us some time to kind of ask some of the questions once we see the system.
Yeah, I'll start this video, and there's no audio, so you'll talk us through it, right?
Yeah, it's just much easier for me to just talk through it. I hope that's okay.
Yep.
So the goal of this video, it's about 4 minutes, 4.5 minutes, is really just to go through the robotic system. This is the T-Mini system. So there's actually no robot. The robot's sterile. Um, and what you'll see kind of in the kind of first view is that really there's the only thing that is in the OR that's not on the back table is the camera system. The camera system is kind of up above where the lights are. So from a field of view standpoint, makes it really easy for the staff to stand around and work on the patient. Your staff, no one has to kind of go hide somewhere and fall asleep while you're doing the robotic stuff. That makes it a lot easier. And one of the nice things that we've kind of, pushed forward recently has been this planning software. So now intraoperatively, we have this sterile touch screen where you can basically plan the whole knee replacement. Now, this is a CT-based plan, so much of the planning has already occurred before you even scrub in, right? So you have the CT plan, we know the sizes, you've looked at really the anatomy, and you've really almost got it perfect. But intraoperatively, you can make changes as you think necessary. Let's say you don't think it's necessary and you just want to go neutral mechanical, that's fine. But what's really nice about the software here is the ability to basically pivot along different points in the system and translate the components, rotate them, and you can do this to plan the actual knee replacement intraoperatively as well. I think you can keep
Oh, it's
going
not
on.
working. There you go. Sorry, that was me. My fault. My
Oh,
fault.
no, no, you're okay. And the system is pretty powerful. You can turn on and off the implants. You can toggle them. You can look at osteophytes. I think once you get the hang of this, you don't have to do all these steps every time. You can kind of rotate every image three-dimensionally, see where things fit. Depending on the system you use, you may want to make sure the sizing is right. From an array placement, I would say pretty standard for robots. Everyone knows you basically need to have some sort of visualization of both the femur and the tibia. These arrays are active, so there are batteries in these arrays, so they're actively transmitting to the camera, which makes it really easy for line of sight. Blood on the arrays basically doesn't matter at all. It's not something you have to think about or worry about, and you can actually intraoperatively confirm on the left side of the screen that you're seeing the arrays. The registration very much is a CT-based registration. So as opposed to non-CT-based robots where you're painting or things like that, this is a CT-based registration. One nice thing are these kind of hash marks that you're getting, these crosshairs, right? You can kind of, it targets where you need to be. The registration really just takes kind of just a few minutes once you get the hang of it. As with all systems, there's a little bit of a few case learning curve. And intraoperatively, once you've registered, you can start ranging the knee, see where you're starting, your varus valgus, your range of motion that you start at. And then you can start stressing the knee and seeing what your gaps are. And I think this is really the magic for me where robotics really shines. You don't have to do this, I suppose, but I think this is really the power of technology today is really to know what the soft tissues are. And you can kind of capture your gaps. Once you've captured everything, as I said, you can go back to this screen and now you have the gaps and you can readjust the implants as you deem necessary, your thoughts, your goals. We can debate this for forever as to kind of what your targets may be. The point being is that you can, choose whatever targets you may want, add some varus or valgus, and we can leave time to kind of discuss what everyone's religion is in terms of kinematic alignment or not. But you can make these choices and changes as you go through this. And again, much of this is pretty much almost done. I mean, you can, play around forever, but at some point, most of the stuff you did pre-op with the CT-based plan and now intra-op, you're just confirming. We do have this kind of dynamic range of motion, which I think is pretty powerful because sometimes just single numbers is not as effective as looking at the whole range of motion and gaps of the knee. So this is kind of the magic of the system. As you can see, I'm moving my hands up and down, but the system keeps that pin exactly where it needs to be, right? So it holds that plane no matter what I do. You can put the pins in at an angle because that's how the cutting block works. But that pin is based on your plan, right? So you've set whatever cut you want on that distal femur, and the robot will put those pins in exactly where you need to. As I said, this is the robot. It's handheld. It's sterile. It's not some big, behemoth in the room where you have to drape it. And it works with cutting jigs, right? So the pins go in, and then you saw basically, as you would in manual instrumentation. The guide for the saw blade is on. Same thing with the tibia cut. You basically plan all the tibia cut. You attach your cutting jig, tighten it down, and then make your tibia cut as you would normally with manual instrumentation once the cut guide is in. Then again, this is the kind of proprietary stuff. So this is where implants, we design this translating block. So the robot puts these pins in, and then this gray block or black block will translate to a specific company's 4-in-1 guide. So whatever, this system was designed for this specific 4-in-1 guide. So it needs that block to translate between our system and the TMINI robot to whatever system you're using. Then you can put all your implants in and trial your motion. And here you kind of see the nice balance throughout range of motion, which is always satisfying to see. A little bit looser laterally in flexion, which is always nice for cruciate retaining type design. So I think that's kind of the quick overview. And I think that it'll kind of leave some room for questions. But I think all in all, that's the general gist of where we stand now. And I think we can move forward. These are some slides to talk about specific cases, but it's up to you, Ira, to see where you want to go. I think you can go back one slide. I can at least show this one case of mine.
Yes, okay, sure. Let's start with
Um,
that.
we can start with this just as a case example. So, um, uh, if you're in, so on the left side of the screen, it says native knee, but basically this would be, let's say, once I've planned the whole case, I've registered, and I've obtained my gaps. Here is the first screen I may see in terms of my numbers. Well, you can see, and only look at the left side here of the screen, and you can see here I've already planned a kinematically aligned knee based on my preoperative standing films that I get. And I've already planned my femur in about 1 degree of valgus and my tibia in about 1.5 degrees of varus based on what I think this knee would need in terms of their native angles at their distal femur and their proximal tibia. And with this, I guess I just happened to get lucky where in extension, the gaps are pretty much similar, 17 and a half and 18. And I think that's kind of a nice target for me with a varus niche, the hair tighter medially to start as we go along with the case that oftentimes opens up. And then on the right side of the screen are kind of minor changes I've made to kind of get us to where I need to be. And so for me, in this particular system, the smallest construct is 19 millimeters. So I usually aim for about 19 and a half to 20. So I'm never the smallest poly at the end. I can kind of jump back and forth. And so I've rotated and changed the implants to what I want at the end of the day. And then I end up with these gaps. So you can see an extension about 19 and a half and 20, and inflection about 20 and 21 and a half laterally. And I usually leave the posterior lateral gap a little bit larger. And so once I have these, I confirm, and the rest is just execution. And I basically make it to the end of the case, and I just confirm we're happy. So that would be kind of a nice case of a relatively straightforward varus knee that I think is worth just starting the conversation off with.
Absolutely. So let's ask a couple of questions here. I'll start with Yair. You have obviously had a lot of years experience with this Team Mini. What have been the challenges or the hurdles for anyone who wants to adopt robotics? Just, because not everyone's using it, not everyone's using this. What are some of the general hurdles you have found in
I
your
mean, I think the simplest one is that manual knees work really well, and philosophically, I was trained to aim for zero within 1 or 2 degrees of zero, and we were probably without machines, we're probably pretty good at getting there with some margin of error. And why change, right? And even in my early robotic experience, where we were aiming for zero mechanical axis, that was possible with these machines, and it was pretty cool that that was happening. But now the philosophies have really expanded, and you go to any meeting, and there are eight, leaders and thought leaders in knee philosophies, and each one of them has a different philosophy, and each one of them is right. So we're now looking at different ways of doing knees, and no, because this is an open platform, and even though I use a certain implant with a certain philosophy that's now a little fluid from what I was originally taught, I don't go for zero anymore. And I've had some experience with medial pivot, which I don't do in live humans, but in cadavers. I'm pretty impressed that if you go way off script from what I was taught, you can actually achieve goals that you couldn't possibly do manually. I mean, there are calipered ways of doing it, and there are some very, very intelligent people who know how to do that with their proprietary techniques. But for everyone to be able to do it, I think it's really, really hard to get those little tweaks that Eytan just showed on his template there. So the challenge, though, is pin placement, registration, and then which is not that bad. I mean, we can all put pins in, but you worry about, if am I going to get new problems now? Am I going to get pin site fractures or anything like that? Registration, am I going to have trouble registering? Is it something that is going to take extra time, and maybe I won't pass it the first time? That hurdle is not so bad for most of us. I think that screen is a big hurdle for some. It's a lot of information, and a lot of us don't know what to do with it the first time we see it. So I think that the classically trained, I know how to do this manually. Why am I going to start adding all these steps to the case? And I think, and what my experience with T-Mini, as well as using some of the other robotic platforms, what T-Mini has shown me is just simplicity. It actually makes all these, like Eytan said, the registration, couple of minutes. It's really not, it's hard at first. There are certain steps. You have to dance a little bit with the digitizer. Once you learn those steps, and please learn them from somebody who does it and has had the struggle, so you don't have to struggle. There are just certain little tricks to do. Once you learn those, it's minutes. And then the screen, and we're going to talk, I think we have a few, that's what I like about this tonight, is we're actually going to address some of those challenges of how to actually interpret that screen, and also where the line is between treating the screen and treating the patient, treating the knee. I mean, we still are in charge of the surgery at the end of the day. So I think the challenge is making something too robotic sometimes, where you feel like you're a bit out of control. And this system helps to bring that back to the surgeon's control just with a GPS.
Great. Jeff, what have been your experience in some challenges adopting robotics, some of the great advantages you have found in your T-Mini crossover T-Mini experience? Let's hear your thoughts, Jeff.
Yeah, so I think, when you're talking about the different screens and the data that you're seeing kind of displayed in front of you, my first case with Roche down in South Florida, we were using Mako back in the day, and then we were also using the Verisense, and so you're looking at all these different numbers. And I don't know if anybody's seen The Hangover, but there's a scene where Zach Galifianakis is sitting at the craps table, and there's numbers just swirling about his head. And I think sometimes when you are first exposed to robotics, that's what it can feel like. It can feel like a little overwhelming. I think the biggest thing incorporating robotics into your practice is trying to figure out what data is important and what data you want to focus on. And so for me, I use kind of a functional alignment type philosophy. And so, I'm looking at the gap numbers and extension, the gap numbers and flexion. And so once you kind of figure out, okay, these are the numbers that I need to pay attention to, obviously you need to know how much bone you're resecting and things like that, but just sometimes that data can be more secondary. And so kind of knowing, I think the other thing that can be challenging is, knowing why something's not working. Is the digitizer not pointed up towards the top of the screen? I think with the T-Mini system, it's fairly intuitive because everything faces up, as opposed to some of the other systems that are using arrays and probes, and you kind of always have to have that array and probe facing towards a camera. If there's an assistant on that side of the table, they have to move, and so there can be kind of cross contamination of those signals. Somebody already mentioned too, if you get a little bit of blood on one of those arrays and then it's not picking that up, it can make things very frustrating. So I think understanding understanding how to make the procedure simple for you with robotics. But I think going from Mako to T-Mini, I think that was a pretty seamless transition for me. I mean, putting arrays in is going to be the same pretty much from system to system, and so I think that is a very easy skill. One thing that I really like about T-Mini is, there's kind of two things you have to learn if you start using robotics. It's one, how to use the robotic system, and then with other systems that are kind of the end effector is attached to an arm that you're using, you have to learn the nuance of making those cuts. And so I think with T-Mini, keeping the saw in your hand, it's much more familiar to make those cuts. And so you're not having to really have as much of a learning curve making your cuts and such. And so I think it's been a pretty seamless transition for me, transitioning to T-Mini. And I think it has all the bells and whistles of any of those other robotic systems out there that you can kind of do what you need to do.
Let's talk a little bit about, and we'll go through some cases in a short while about choosing implants or choosing a robot. Because it's one of the things about an open platform. Eytan, now that I believe that there's an array, no orthopedic pun intended, of implants available. Um, are you choosing robot implant? How does that work out?
No, I think it's one of the beauties and kind of I think core guidelines of the guides of Think as a company. They've been very keen on keeping it as an open platform system, with the idea that as computers are, you have your technology, and then you can add whatever applications you'd want onto that. And I think as surgeons, we all have certain systems we believe are useful. I'm a big religious believer in medial pivot, and my friend Yair isn't, and we can disagree on that, and that's okay. But I may choose to use a certain implant, and he can choose to use a different one. Doesn't mean we have to use different robots, right? So now we are pretty well versed in using the T-Mini and can be efficient and productive and treat patients well with the robotic system to get the cuts we want, right? But then we can also choose our different philosophies when it comes to implants and what may be best for certain patients. Let's say you like medial pivot. Let's say you like certain CR design. Let's say you like an implant that adds some sort of degree of slope or something in your implants. Let's say you like a certain press fit implant. Use what the implant you like to use, and then but this way choose a robot that allows you to do that. And then and T Mini is a robot that has kind of democratized robotics for the masses, in my opinion. I think it simplifies it. I think it makes it more straightforward. I think as Jeff said, the saw blade in the surgeon hands keeps it basic. And the CT planning, I was back and forth on this. I think I felt that I was pretty good with a non-CT based robot, but then I realized as I was doing much more CT based type robots is that 90 to 95% of the planning is done, right? You may add a little tweak here or there, but it's hard to mess it up a whole lot more once it's all been planned on a CT, right? So many times you don't even have to do a lot of the changes that you need to, that you may want to do on that, complicated screen, and you're already there. With the non-CT based robots, it can get rather complicated, and it can make a lot of changes until you get where you need to be.
I want one of you guys to talk about real complex deformity cases. Is there a role? Does the robot help out more on those types of cases, or is there a case that's too complex for the robot? Maybe Yair, you can answer that. It's someone, yes, it's just, those big bone deformity, 30-degree valgus, 20-degree flexion contracture. Yeah, those
So
kind of.
I mean, so been there a little bit. Did some pretty bad ones, and I think this goes back to one of the things that I think T-Mini makes possible is that those tweaks that Eitan's talking about, the little tweaks, once you've corroborated that CT anatomy with the registration anatomy in the OR, it's pretty remarkable how probably wrong we get it with manual instruments on these complex cases that we're concerned about doing just right. I don't know that I know how to adjust the 3D position of the femur just right for a bad deformity, and I've had a few surprising bad valgus knees that I didn't have to do any or very much lateral pie crusting where without question, classically I would have had to. And how it's remarkable how little medial releasing we're doing, basically none. Where not that long ago, a few of us were trained, I mean, you've seen the osteotome go all the way down the medial leg not that long ago, right? I mean,
Right?
almost down to the ankle we were taught, right? And I don't remember the last time I took, that there was an osteotome near the medial side of the knee. So this thing can and not just this robot, but here I find it so easy with this particular robot where we're able to hit the mark and really respect the patient's soft tissue. Where I think we used to kind of ignore the bony cuts and just make them cookie cutter and then deal with the soft tissue. And then we called that a successful, balance. but that's because we had to stretch out tight tissues that now we might not have to do anymore. I mean, I'm my other hat. I'm a sports medicine surgeon, so I have to reattach ligaments from point A to point B. If the bones are in the wrong place, right? If I put those points in the wrong place on a sports case, I did a bad job, right? So why isn't that the same thing where if I cut the bone wrong and I change the way the ligaments go, that's probably also bad, and we're not doing that anymore. So if we're changing where those ligaments are supposed to be, that's probably why patients had I think, I mean, I think they're in less pain now because we're not touching their soft tissues, even in those deformities, Ira.
Interesting. Jesse Klein, I saw you had a raised hand. I don't want to put any pressure on you if you had a question or you just unmute yourself and ask a question.
Hey, Dr. Kirschbaum, that was a mistake, but I'm very much enjoying the content.
All right, all right, all right. Raise your hand anytime. It's fine. It's fine.
Thank you, thank you.
Okay. Laura, you had a question. Laura Wynn. Did you?
I did. I think, we went from manual surgery and now these big robots and these smaller robots, um, robotic surgery. Where will mixed reality surgical technologies fit into the future of arthroplasty? Will
Yeah.
they?
And you guys want to take that one on?
I've tried, so DJO has the AR helmet. It was an interesting.
Polaris is another one, right? Polaris AR.
I'm not sure. I very limited experience, and it was an interesting but rough start to something that might one day. I mean, I remember the first robotic lab I did, and the robot cut the patellar tendon. So in a lab. So I remember that, and luckily that doesn't happen anymore, right? So I think there's going to be a role for it, but maybe it'll help in registration is my imagination, or possibly a dynamic assessment of that knee. But yeah, I think time will tell.
Yeah, I have a question to Jeff. Jeff, we sometimes have said this before on a number of innovations that we explore in Joey. If Team Mini, this open platform robot, came out first, let's say 8 years ago, 9 years ago, would anyone think of doing one of um, the trailer truck robots, for lack of a better word? Um, all the other companies have them, or so what do you think about that concept? It's like having an iPhone first. Would you think of then getting film? You know, sending it to the 1 hour photo place.
Yeah, no, I mean, I think that's a great question. I mean, um, I think T Mini has, the big robots came out first and kind of established this idea of being able to be precise and execute on that precision. And T Mini has kind of, like you said, has kind of simplified that process and kind of distilled it down into a smaller, kind of more easy to use package there. And so, it's always hard to say. If I always tell my patients, if I had a crystal ball and could tell you, I would. But I think that it's kind of reverting back to a simpler form. It's going to be more natural for somebody that hasn't done robotics before to use a handheld device to drive your pins in, to put your cut blocks on. Like, cut blocks feel familiar to orthopedic surgeons that do joint replacements. And so, with T Mini, I think, putting the pins in, putting the cut blocks on, that feels like a normal workflow. And so I think that, maybe there wouldn't have been big robots that you wheel in to make bone cuts had this been out first. But I think sometimes you have to, the goal I think with robotics is precision, and so initially precision had to be carried out with these big machines that could lock into place and have haptic boundaries, such yada yada yada. And we've T Mini's now found a way to kind of deliver that in a handheld form.
Interesting. I'm going to bring up my screen again. Yeah, this is a case you had. You want to give a talk, tell us a little bit about this? We'll do
Yeah,
your
no, this
case and then
is
we'll do Jeff's case.
Yeah, this was Monday. Yeah, this patient's already, jumping rope and running a marathon already by today. This is actually one of our anesthesiologists who came in for his second knee, and pretty nasty varus. And these are his max gaps on the left. As Eitan said before, native knee just means the pre-cut assessment. And what you see are, again, a little bit of information overload, like Jeff said, but just to water it down, you've got your max gaps, medial on the right, lateral on the left, extension up top, and flexion below that. So they are matched to each other somewhat, and a little bit tighter on the medial side, as one would expect on a varus knee. My approach to this is I'll start on the tibia, because tibia affects both, obviously, as we know, but I'll give you a little anecdotal case that I had a couple of weeks ago that without the robot, I would have done a worse job. With this information, I think I did a better job for the patient. So I started on the tibia, and what's nice about these screens, we can anchor where we want. We have choices of anchor. So we can anchor in the middle. And if you think about it, when you're doing a manual knee and you start tinkering, you're rotating from the middle. And rotating from the middle really loses control of both sides. Whereas here, if we could just go back one, sorry, if I want to anchor, keep one of the gaps the same and change the other gap, I anchor on the one I want to keep. So in this particular case, I would have anchored laterally and then kicked the tibia into a little bit of varus, opening up the medial side in both flexion and extension. There's no way you could do that manually. And then in his case, I don't mind having a little bit of tighter medial. I do a medial congruent poly a lot of times, and that's the philosophy I like, or ultra congruent in another system. So I like to keep that medial side nice and tight. I feel a tighter medial side's a happier knee. And then it gives you your correction. And then so this is kind of what we did. And after I move the tibia, I might adjust a little bit of more varus on the femur by anchoring laterally. Then I go into the flexion. So it's tibia first, maybe a little tweak of the femur in extension. Then I look at the flexion gap and I might adjust that rotation of the femur, which I don't think we can, right? We either do 3 or 5 on everybody, right? Or right? I mean, right? Or 0, I guess, if you're another philosophy. But we don't personalize that in any way to the patient. Those are arbitrary numbers on the cutting jigs. And then once I've done that, I'm going to rematch that femoral and that flexion and extension gap by maybe moving the tibia up or down, because I'm going to also shoot for, in this system, a 10 block is 19 millimeters. So I shoot for about a 20. If it's a tight guy, I might shoot for a 20, 21, knowing that they might be a little tight. Keeping in mind, if this guy, and this is what's the beauty of the CT scan, if you know you have large posterior osteophytes, I try to be a little careful there about how much I take distally on that femur, because I know that I'm going to loosen up that extension gap after I take those. So that's a little bit of a little nuanced learning curve, I think, is to predict a little bit about what you're going to need to do after you've cut. You can't know that until you've cut the bone. So then the next screen, this dynamic assessment that we were talking about, on the left is the pre-cut dynamic screen. So you've registered the knee and now you put it through a range of motion. As you can see, the medial side throughout the whole range of motion is significantly tighter than the lateral side. And once we finish, and this is with our trials in, that's a nice graph. And that's, to me, very satisfying. I think jumping ahead in the future, this might give us an opportunity to identify mid-flexion instability, for example, which is not so easy to identify until the patient is complaining to you 6 to 12 months later that they're not happy going upstairs. And you don't know why, and then it's probably mid-flexion instability some of the time. Here, if you see that there might be, you might change what kind of poly you use. You might consider using one of the semi-constrained polys or what, or change something to help that. And this might let us better understand how a knee actually moves from zero to flexion. So this is a very satisfying result. And you see that objectively. Orthopedic surgeons like instant gratification. And here, a few minutes later, after you've made some changes, here's your result. I think we could all be pretty happy about that when we get that.
It's great. Any comments on that? Jeff, has that been your experience too?
Yeah, I think, one of the things that you were saying is, that choosing your anchor point there. I think that's something that you don't realize how nice it is until you can do it. And so when you have numbers that you like on the medial side and you want to either tighten things down or open things up, you can just kind of use those anchor points to kind of affect that change. I think, and I'd be interested on the other panelists' thoughts here. Um, I think using robotics has made me a better manual surgeon because I oftentimes find myself kind of, looking at things and saying, all right, here I think I'm a little tight or loose. How could I, change this 4-in-1 cut block? Or, maybe I dial in a little bit more valgus on my distal femoral cut, or, there's all these little things that I'm thinking more about those because with the robot, you can kind of make those live changes. Um, but yeah, I think that's a great case, and I think that's very similar as to kind of how I go about balancing my knees. Kind of get the numbers to match side to side, then move your tibia and femur up and down as needed to kind of balance those spaces. But for me, I think you had asked the question of for the really bad severe deformity cases, is that does it make it is the robot good for those? I think the robot's even better on those big deformity cases because you can kind of dial things in more precisely. Because I think trying to do that with mechanical instruments can be a little challenging, whereas the robot kind of gives you free reign on kind of rotating things, especially when anatomy is not familiar because there's deformity or whatnot. So my case will demonstrate that a little bit.
Yeah, we'll go ahead in a second. Eytan, Jeff talked about touched on a very important concept of some people think the robotics take thinking out of the surgeon's mind and you end up being a robot yourself. But I'm getting a sense that you actually evolve better as a surgeon through getting all this information. What are your thoughts about that?
Yeah, I agree with the latter. I mean, you could take it either way. I mean, let's say, you just take the robot at face value and just make the cuts at to kind of whatever was planned on the CT. That's fine. But I totally agree that using a robotic system, and it takes time, and you do a few cases and you see how they turn out, and you tweak something here, tweak something there. But with once you have a few cases under your belt, suddenly you start looking at knee replacement very differently. And it's a world of difference as to compared to where manual instrumentation is, whether you're, measured resection or gap balancing, it suddenly adds a whole new depth to knee replacement overall. And I agree, it does make me a better manual surgeon. Suddenly I'm trying to pivot, on my own in manual instrumentation and futzing around because I know I'd like to achieve a certain gap, because I could have done it with the robot in a certain way. Same thing with a tibia cut. I just don't think we're as precise making varus cuts on the tibia, as much as the robot would be. So, from that standpoint, I do agree that it's made me a better surgeon and has also allowed us to look at knee replacement in a whole new world. We're doing a lot of research at HSS, and a lot of it has to do with measuring the changes we can make with robotics rather than the changes we can make anymore with manual instrumentation. Very, very difficult to kind of actually quantify any of those changes with manual instrumentation. With robotics, you can.
So we have a couple of questions, but first I want to go to Jeff's case so we don't lose time. As I always like to say, this is the fastest hour in orthopedics, faster than a Charlie de Cook hip and knee. Okay. Um, Here we go. So tell us what's going on here, Jeff.
Yeah, so I apologize that I don't have the intraoperative numbers that we generated for this one, but this was an unfortunate lady that has pretty significant osteoporosis that was treated, but you can see bilateral hip fractures with long nails in there, and a tibial nail and an ankle fracture. And so my trauma colleagues fixed her all up, and then they said, "Hey, she's also got this really valgus knee now. Can you help us out?" And so, um, one of the nice parts about being at a big institution like Ohio State is we got everybody has their niche, and so my trauma colleague went ahead and, you can see that nail up top is kind of backing out. The lag screw's backing out a little bit. And so they were going to exchange nail her to a shorter nail to give us some room to work down there in the femur and then take out the tibial nail as well. And so we let them go first and go ahead and take out the nails. And then we got to work. And so, she had a really interesting knee. I think she definitely had some internal rotation of the femur at the fracture site proximally. And so the anatomy was a little bit interesting, but, she had it was a very fixed deformity, probably, I don't know, just eyeballing that. Looks to be 15, 20 degrees of valgus. The internal rotation kind of made it very hard to balance that lateral gap. So we were able to get her really nice and squared away. I put the femur in a little bit of extra valgus to kind of match her femur there, and then we're able to get the leg pretty straight. And I apologize for the lack of post-op films there. She's only a few weeks out now, and so we haven't got her formal standing X-rays back in the clinic just yet. But overall, it really helped get our extension gap kind of perfect there. We ended up using a varus valgus constrained knee because there was some gapping that couldn't be reconciled with balancing the soft tissues. But it really helped us kind of execute getting the extension gap perfect. And so this is just goes to show that it can be used in very complex cases as well.
That's great. Hold on a second. All right. Hold on. I'm going to take this out for a second. Marty Nichols, you had a quick question there. Marty, you want to
Yeah,
unmute?
no, I was just kind of curious. I love some of this stuff. I actually have two parts to this question. But number one, are you actually doing this product disservice by calling it robotics? Because some of the public now tends to wonder, when you say robotics, is a surgeon actually doing my surgery or some robot or some arm doing it? And then for the surgeons that really haven't looked at or adapted robotics, they think of a robot as a big mechanical arm and something that needs to be draped, and everything else, where this is really more of surgeon augmentation. I mean, this is literally just giving surgeons data and then allowing them to execute to the data. And I kind of wonder if there's a little bit of almost hurting yourself by calling it robotics, number one. And then number two, in your couple of your planning deals and stuff, when you guys were talking about 1 degree of valgus in your distal femoral cuts, I assume you're talking off an anatomical axis rather than a mechanical axis when you're looking at the 1 degree on your femoral valgus.
Who wants to take those questions?
I'll step in and take it. I would say, if I think would say that this is robotics reimagined. So, I think it's changing the paradigm on what a robot is and how it helps us execute that plan. And as far as the 1 degree of valgus, 1 degree of varus, those are off. That's typically referencing what you planned, and so whatever you planned your implant in, then the adding the varus or valgus is the deviation from the initial plan that you have set.
And I would just add, yeah, that's a great point. I would just add this. I thought about this question because I think someone has asked us this before, and I thought about this a lot. So number one, there's a legacy, there's a history. This technology didn't come out of nowhere. It came from a very, very developed robotic arm, autonomous robots. So it is a robotics company. I think it would be kind of hard for them to not call it a robot. And also just calling it something else at this point might be misleading as to where it's come from. Because at the end of the day, it is using that robotic technology that was an arm and did went to town on the knee, on its own while the surgeon watched it go. And it is still that same technology that's doing it. It's just smaller. But I thought about this a lot because we have been asked this before, and this thing here is called a telephone, right? In what way is this a phone? Okay, this is a laptop computer. It's a map. It's a stereo. It's right. I hardly we don't even call people anymore, do we? I mean, we send each other audio messages or WhatsApp or right, but we call this a phone, right? So in the same way that a rotary phone is a phone, and so is that, I think that you can call this a robot.
I looked up the definition of the Roomba. If you remember, the Roomba was a vacuum cleaner, and it's not a robot holding a vacuum moving the arm. So I asked Chat GPT just 2 seconds ago, is a Roomba a robot? It says yes. It is a. Let me get exactly what Chat GPT said. It is a autonomous robotic vacuum cleaner. It is a robot. So it's interesting. And it doesn't look like a iRobot robot vacuuming the floor for you. But it's a great question, Marty. Chris Jones had a question. He can't unmute because of his background noise. His question was sorry, how are hospitals and facilities that handle multiple brands that are accepted on a T-MIDI platform handling the purchasing process of the robot? Is there add-on like if at I'm sure at all your hospitals, I mean, one of you guys uses Zimmer, one uses Innovus, and another one uses a different Zimmer product. Is there any adaptation you have to do in the T-Mini robot with the different platforms? Are there add-ons for different companies, or is it just the same robot? You just get the four-in-one block from the company, right? Is that it?
Yeah, the proprietary tool is just that one piece. The cutting block is the same for all the cases. The pins are the same. The robotic handpiece is the same. The overhead's the same. There's just that four-in-one little rectangular block that is proprietary per implant. Sometimes it's A ref, P ref, doesn't whatever it is that you're doing for that implant.
Great. Omar Khatib, you're on board. You have a question. You want to
Yes,
unmute?
can you guys hear me okay?
Yeah. How you doing, Omar?
Perfect. Perfect. I'm doing great. I'm loving this discussion. And Dr. Kissin, that's probably one of the best analogies I've heard in a long time about how you've kind of redefined like what a phone is. So my question is this, actually earlier this week, I had a post from some market research company, which I use their stuff, but I'm being blamed for misinformation because the market sizes were off by a little bit. But if we look at orthopedics, like the main players in robotics would be like Mako from Stryker, the Smith and Nephew robot, and then I guess the Rosa from Zimmer. So my question is kind of twofold. One is like, in your mind, what does Think Surgical have to do on the re-education and redefining of a robot to get surgeons to pay attention more? And the second thing is, if somebody were to, let's say, move away from doing Makos, right, or any other like robot like that, what do you think the main reason is that they would say, you know what, I'm going to do like less Stryker Makos or less Zimmer Rosas, and I'm just going to be using the T Mini all the time? What would that scenario look like?
Let's start with the second question first. Okay.
Yeah, I think that was more complicated. Good point.
I
Good
like
call.
I got the second question first. The conversion. I don't
Yeah.
know. Eytan, were you originally something not T-Mini?
Yeah, I've used Rosa, Mako, Cori, Velis, and multiple nav systems. I think, each surgeon is different in terms of why they may switch. I think it's multifactorial. I think, we talked about the simplicity, the ease of use, the small real estate, the lower cost, the open platform nature. All those are great reasons to use T-Mini. I think let's say you have a great robot that works with a certain implant and you want it to switch. It just, you may switch because you want to use a different implant. Let's say you're not satisfied with the striker knee, but you like to make a robot, but you don't believe it's the best knee for your patients as another knee replacement that's better, then that may be a reason to switch. If you have a surgery center, you have multiple partners who have used different types of implants, so you all want to just purchase one robot that's just, nice small robot for a surgery center. It's another reason to potentially switch. I think each place is different, and a lot of it goes to the question even before the finances of each institution and what they're thinking of in terms of expansion and growth.
I think what I hear at my place is the current robot users, some don't like the robot, or they like the robot, don't like the implant, like what Eitan's alluding to, because they're locked in, and this gives them that choice. But the other one I hear a lot is that I just can't seem to get this particular robot to be any faster than about 20 or 30 minutes extra time. And that's definitely a complaint. The implant and the amount of time that it takes people to do the robot, the first generate, whatever we're calling them, the bigger robots. And I think that the ease here, so it kind of answers both of your questions, Omar, I think is the re-education is that we can still give you a robotic outcome, a robotic surgery, but it's actually easy. I think it's a compliment that people are saying that this isn't really robotic, because it's that easy that it all of a sudden, and techs are coming in and the surgeon next door is coming in. I want to see your case. And you say, well, it's over already, and they went and did a rotator cuff next door, and they want to see what the T-Mini is like. They come in, they've tied their knots on their rotator cuff. The PA is closing their shoulder portals. We're done with the case already, so it's that easy. It's not that impressive. That's true. It doesn't look so impressive. It looks that easy, so I think that re-educating, Omar, to your point, is re-educating that it doesn't have to be that complicated.
That's fascinating. Vincent Palmer, you had a question. You maybe the last question for the night before we wrap up. Vincent, you want to unmute, ask your question? I think it's a solid one. Oh, well, I'll ask it for Vincent.
Sorry about
Oh, there
that.
you go.
Walking my dog.
Oh, that's
Walking
all
the
right.
dog.
More important. Yeah.
You caught me off guard. My question is, I'm a long time Biomet Zimmer sales rep. Does the Think Mini have an indication or application for the Oxford knee for tibial slope, pin placement, and like implant positioning of the femur?
So, this is where MDs and PhDs want to shoot each other, because you go into a room and the surgeons say, can we turn this on for unis tomorrow? And the engineers jump out the window, right? I think that it's a lot harder. Right now it's indicated for total knee, but obviously we're Eitan and I are part of those conversations, and lots of options to work with here on what can be next. But yeah, pin placement obviously in orthopedics goes far beyond knee surgery. So there are definitely applications out there that can be thought of for this device, and are being thought of, but not available yet, Vin. Sorry. One
Right.
day.
So we're at 8:58, so I'm going to ask all the panelists to just say a few final words and summarize. I'll start with Jeff from Ohio State University.
Yeah, so thanks for the invite tonight. I really had a good time talking about this stuff. It's something that I'm passionate about, and it's always fun to talk with other people that are passionate about this. But, for me, the transition to T-Mini has been pretty seamless. Being able to use an implant that I can use for every case and not just some cases has been kind of transformative to my practice. And so I'm really excited for kind of continuing to kind of see the evolution of the robot. I'll use the word robot.
Go for it. Yair, some final
Yeah,
comments?
I would add the only thing that I think I didn't mention yet, just to say something different and new, is that I've really enjoyed using this as a teaching tool. So as I look at who's on here, a couple of my residents, my students, my rep, and one of my OR nurses who scrubs with me sometimes, it's really nice that we don't have to empty out one side of the table so we can get line of sight to do a robotic case. It's nice that we can still all huddle around. I have four people around the table for most of my cases. And I've had my students and residents do the registration and the placement of those robotic pins and demonstrated just how easy this is to do. I don't think you can do that even with a manual knee. I don't know that I could let go of the reins that easily. So using this as a teaching tool at a university hospital, I think is really valuable.
Amazing. Eitan, you want to bring us home?
Yeah, sure. I think Jeff and Yair said it well. I think it's been a pleasure to have me tonight. It's great to chat about the system. I think TMINI brings a lot of new, ways of thinking in terms of robotics and knee replacement. I'm excited to see where we go from here. I think if anyone hasn't seen it, come see it, at a nearby booth. But there are a lot of videos now on YouTube and things you can visualize there. So if you want to actually see a full case, please feel free to go onto YouTube, watch it. And obviously, always feel free to reach out to any of us with any questions. So thank you for having us.
All right. Well, this is really always my honor to have panelists like this and innovation like this. Um, and that's what the journal and that's what these topic sessions are all about. So I'd like to sincerely thank everybody for coming tonight. Some really pointed questions, bringing some things out to the forefront. So I'd like to say good night.